Okay, welcome everybody. I am Sharice Magoon and I work in the Department of Lifelong Learning at UT Health San Antonio School of Nursing. I will be moderating the session today. Earlier this morning, you were sent an email from Cynthia Gutierrez, and at the bottom of the email, it explained how to complete your evaluation and how to get your certificate. So if you have any questions regarding that, just get with her after the presentation. She's going to type her email in the chat comments. So if you need to contact her. This symposium is sponsored by Texas Health and Human Services Commission in partnership with UT Health San Antonio School of Nursing. Texas recognizes June as Neonatal Abstinence Syndrome Awareness Month. You can learn more by reading House Bill 405. During the presentation, we ask that you keep your camera and your microphones off. If you have any questions, you can go ahead and type those in as you're thinking of it in the chat box. And Tara will address those at that time, so don't be shy. And we are recording this session, just so you know. Before we get started, I want to introduce Tara Sundin, is a board certified neonatal nurse practitioner with more than 28 years experience in neonatal intensive care. She was a frontline worker in the growing opiate epidemic, caring for the most innocent of victims, newborns suffering through opiate withdrawal, neonatal abstinence syndrome. Her passion is to transform the healthcare experience for them and their families, led her to found Hushabye Nursery, an Arizona nonprofit dedicated to caring for opioid exposed newborns in their first weeks of life. The 12-bed inpatient nursery opened its doors and its arms to these babies and their mothers in November 2020. Under Tara's leadership as executive director, Hushabye Nursery has grown from an idea to save the babies in 2016 to a new, unique model of care for the underserved population that focuses on the family unit, both perinatal and postnatal. She is recognized as an industry leader in NAS. Tara has presented several community events on the topic. She received the 2021 Phoenix Business Journal Healthcare Hero Award for Nursing and a 12 News Miracle Makers Award in 2021. She holds a Master's of Science from Arizona State University and is a member of the National Association of Neonatal Nurses, the Academy of Neonatal Nurses, and the Neonatal Nurse Practitioners of Arizona. Before we get started, I'm going to play a video.
You know, I was scared. I was scared to death.
Scary. I was really scared. It's my first child, so.
It all started because I was in a car accident, a really bad car accident. So I got on to the pain pills, and it was, they didn't tell you, you know, about the withdrawals or the effects of it or anything. So I got addicted to them because I was taking quite a few a day.
I didn't know at all that she was going to be, you know, substance exposed or whatever. I wouldn't even think of that.
And then when my grandma passed away, I relapsed. And then I found out I was pregnant, and my fiance helped me. He found a methadone clinic for me because I said, well, you're pregnant, so we have this program called Hushabye Nursery, and her name's Tara, and do you want to, you know, call her?
My colleagues here in town said you have to meet Tara. She's creating something that's really cool and in a similar spirit as the work you're doing, which is putting together a really innovative healthcare model for people who need it the most.
I am a neonatal nurse practitioner by real job, taking care of babies, and probably 4 years ago now, it's been 5 years ago, we started seeing all these babies coming into our neonatal intensive care units withdrawing. It's horrific to watch. Once you've seen one baby withdraw, you'll never, ever forget it. And if there's anything that we can do to make it even a little bit better, we should be doing it. And believe me, these moms and dads want that. They know how awful it feels.
You still feel guilty, you still feel horrible because your baby's gonna withdraw. She's gonna be, having these horrible feelings that I can't even handle as a grown adult, let alone my newborn baby's supposed to be fighting that off.
At the methadone clinic, when we had the Hope pregnancy class, they gave us like a green binder and gave us all kinds of resources and lessons, and showed us how to give baby massages, and they just gave us all the tools that we were going to need really to have a baby that had neonatal abstinence syndrome or whatever.
But seeing these families like just thrive and do so well, and see that I can take care of a baby, but if I can teach the family how to do what I do, that baby just responds, and it's like, look at that.
So the mission of Hushabye Nursery is so unique because it touches a point in life, in a newborn's life and in a mom's life, that's so pivotal. And I think it can be a watershed moment for multiple lives at the same time, for the trajectory of a newborn to have a better chance than they would have otherwise, for a mother to have an opportunity to press pause and really take a look at how she wants to be a mom to this new baby, and to give them that chance in a very low barrier, non-judgmental, inclusive environment, is just an opportunity not only to change one life, but multiple lives represented, mom, baby, and family.
Tara's kept in constant contact with us ever since we had the baby. She's texted us, several times a week, asking how the baby is. If we ever have a problem, she knows exactly what to do with the baby, and so we can just text her. And she doesn't judge. There's no condescension or anything like that. She's really, really open-minded, and she just is. She really, really helped us with giving us the confidence to know that we were going to be able to take care of her.
And when I meet a family for the first time and I tell them congratulations, they look at me like, and then they're like, oh, thank you. They're totally taken by surprise because they haven't been told that, and they just want to be good parents. So now our care model is not just that bassinet with that baby, it's really the entire family and trying to heal them.
I would say just reach out to, Hushabye Nursery or to, and Tara, because she literally saved mine and my family's lives.
You and me.
Okay, everyone. Thank you so much for being here today. We're just gonna get started. I do want to just start with, please ask questions. I totally do not mind. I'd rather have it be interactive. I know it's virtual, but if we can do it that way, I think it is best. A little bit about Hushabye, and really I was asked to just kind of speak about how we got to where we're at. And me putting this presentation together, I was like, oh gosh, I remember that. That was hard. It took a lot of persistence and a lot of begging from community partners, from our government, from just our families that we've served. I saw in the chat, how brave of these families to share their stories. And I have family after family right now that are waiting. They want to tell their story. They're proud of where they're at now, and they really want to be able to give back. So as the videos showed, we started initially as a save the babies. That was our plan. My girlfriend, who's also a neonatal nurse practitioner, was watching the TV one day, saw the Today Show, and on the Today Show was Lily's Place from West Virginia. And what they had done was they, out of community need, and their NICU was completely full of babies with neonatal opioid withdrawal syndrome, or NAS, at the time. And they took babies that with NAS or NOWs from the neonatal intensive care unit to their nursery that just was made specifically for babies. Quiet, dark environment, just 1-to-1 nurses, or 1-to-2 nurses, I guess, or one nurse to 2 babies is really what they were doing. And we were like, oh my gosh, my girlfriend was like, we need to do this. I'm like, we are not business people. How in the world are we supposed to do this? And we kind of just poo-pooed the idea. And then we started to see more and more babies coming into our unit. And it was like, where are these kids coming from? Prior to this, I spent 17 years in a level 3 NICU that at any given time we had 80 to 90 babies. I every day took care of 15 babies on my NMP team. We admitted these little ones, but then they never were on my team to take care of. We put them on the doc team just because the doc team was a little bit lighter because they had to round on everybody. I had no idea, and I should have known, that these babies were in our unit, that they were with us for months long. And at this time, I ended up being in a little community. I had to do my stint there, and it was a six bed nursery. And we started to see truly what this trend is, what I'm showing on the screen. But we would have 5 to 6 babies withdrawing at one time. And it was in the community that I lived in. It was in a very nice area, and I was just really taken aback. And so, as you can see, with the opioid crisis, the numbers have skyrocketed. Since COVID, the numbers continue to go up. We in Arizona are leaders in fentanyl overdoses, definitely not what you want to be, but we are seeing more of an uptick in the babies that are withdrawing. We also are seeing more home births occurring because families are scared to death of the system and they really want to parent their babies. And so they're trying to see if they can get by doing it that way. I'm sure you guys are all seeing the same thing. The national incidence of NOWs from 2016 was 7 births per 1,000. You see the highest rate with the Native population. I will tell you, our demographics of the families that we serve here at Hushabye, we're not serving that population. We're trying to get to them, but that is not what we're seeing. So we know that there are so many other families out there that need to be connected with us because we can help them. We all know that the rising costs for families or for babies in the NICU, average length of stay for a baby with neonatal abstinence syndrome or NOWS, most of the babies that I care for with are polysubstance. They're exposed to multiple substances, unless mom's well and is on medication assisted treatment. But for the most part, I truly say NAS because they're withdrawing from something else plus an opiate. Sorry, I forget where I was going with that. Oh, but the national average is 21 days in the NICU for a baby that is withdrawing. Our average length of stay is 7 days at Hushabye. When you look at national average, anywhere from $2,400 to $3,200 a night in the NICU at times 21 days, you're looking at $40,000 to $60,000 for a hospital stay. Hushabye is less than $1,000 a night. So you're looking at from $40,000 to $60,000 to $7,000, kind of a no-brainer. Besides, we'll talk about outcomes and where we're at. But how did we get where we're at? So initially, our plan was, let's do what Lily's Place is. We went and visited. Bridget's Path is another organization in Ohio. They're about 2 hours apart. We went and visited both, learned from them. They told us there are things that didn't work for them and what we should do. We came back to Arizona, and at the time, our governor had just put together a substance abuse task force. And when we looked at who was on the task force, we're like, oh my gosh, one of the doctors that trained me was on the task force. And I was like, okay, what are you doing? And how do we get involved? And he was like, please come and say, tell them what you want to do. So we went and presented, and they were like, oh my gosh, do this. They asked what we needed, and we said we needed a building. And they're like, oh, we'll find you a building. I'm like, okay, sounds great. But the one thing that they asked at that time, and this is 2016, they said, so what about the moms? And then we were like, well, no, we can't do the moms. We're neonatal nurse practitioners. We can do babies in our sleep, but we don't know behavioral health. We don't know any of that. So just know that's 2016. In August, we were connected with a fiscal sponsor. They taught me how to do a budget, which I'm learning as we speak. They helped us do business plan and trying to create that, and then connected us with a couple key retired business people. One that was a CFO in her organization or in her lifetime as prior to being retired, and she helped us do everything for free. And then really we focused on networking. Every meeting that I went to, I asked for 5 people that I should talk to. And I went and talked to everyone. I needed everyone to know what Hushabye was about. As you can see, this is just a headline from the Today Show of what Kelly was watching when she heard about Lily's Place. In 2017, I was asked to be a subject matter expert, which I was not at the time, but they wanted me to talk to a developmental group here in Arizona about neonatal abstinence syndrome. I'm like, well, I can do that, but I don't know how to, I don't know anything else besides how to care for a baby that's withdrawing. And when we were doing that, there was a psychiatrist and a psychologist both in the audience, and they asked me about ACEs. And I'm like, I don't know what you're talking about. They're like adverse childhood experiences. I'm like, nope, don't have a clue what you're talking about. I went home, read about them, and I went, holy crap, sorry, bad mouth. I was like, what are we doing? And so we very quickly went from save the babies to truly save the families. Babies that I'm working with, for the most part, are born right when they're born with at least 2 ACEs. You have substance use, and usually mental health goes along with substance use, meaning depression leads to substance use or substance use leads to depression. I don't think I've ever met a mom that hasn't struggled with both of those. Then you have, poverty, no housing, lack of food, single parent, someone in prison. Our babies are very much impacted by adverse childhood experiences. For all of you in the audience, I'm sure you do know this, but 4 or more is the magic number for we're putting a baby at risk for their entire life for chronic illness. We continued in 2017 networking. Every person tried to put together a board of directors. And so many people said, how did you get your board? And I was like, I just went and talked to everybody. And Brandon, who was on the video, I did ask him. He was like, yes, I will. He created a homeless hospital here in Arizona. He was at the very first year of that creation. And so he's still on my board, still helping us. But we started, I think my board was 6 people, and now we're about 14, all from different entities. Whenever we need something, it's like, okay, now we need to be connected with a lawyer. Now we need to be connected with, you know, a behavioral health person. And then we start asking around, seeing if there's any interest. And there's so many people that want to give back. We have been very blessed. 2017, we dealt with a lot of naysayers, many people saying you can't do it. How are you going to get paid? What are you going to do? That it can't be done. It's never been done. I had one person tell me, absolutely, you can't do it. My husband to date still says, he's like, why did that person say that? Because it was a challenge, and we ended up doing it. So in 2018, there was, the state had said they were going to help us with a building, and that proposal ended up falling through. So we were like, okay, well, now what are we going to do? How are we going to find a building? How do you even find money? If you don't have your 501c3, so your nonprofit status for 3 years, for most grant funding, you don't even qualify. So how do you come from, you know, a nurse practitioner? I'm doing everything for free. Kelly's doing everything for free. My board is doing everything for free. But how do you get money? Our fiscal sponsor, Vitalist Foundation, gave us our very first $10,000. I can remember being so excited and just being like, oh my gosh. Now $10,000 is okay money, but we really are always looking for bigger grants that we're, you know, going for. Very quickly, how you go, your mindset goes. We then, at that time, my kids were in high school, and they were in a business class. My oldest was, and they had to talk about, what do your parents do? And my son was telling them what I was trying to do. And one of the his classmates' parents owned one of the medication assisted treatment programs, so one of the methadone clinics in our area. And she reached out to me and said, would you be willing to meet moms at our clinic? And I was like, I can try. And so what we did was, once a month, I would meet for 1 hour the pregnant moms going into the clinic. And sometimes dads would join. I didn't take any names. We weren't billing for it. We weren't doing, I didn't think, anything besides helping educate them that Department of Child Safety was going to be involved, helping them understand that you make everything better. They need you present, to turn down the lights, to make it a quiet, dark environment, to make it like you and I need to, the environment that we put ourselves in when we have the flu or a migraine. That is what we needed to do. And then as we were doing this, I started looking at outcomes, and we had 12 moms, and 10 of the 12 took their babies home with them. And I was like, oh my gosh. So then I started collecting data, and I was like, oh yeah, mom with blue hair, mom with purple lipstick, mom with no teeth. I know that's awful, but I was trying to then like backtrack because I didn't have their names. That data, just knowing which babies were treated with morphine, which I think we had only treated 8 of the 12, and 10 of the 12 had went home with their parents. We started to talk and tell other members in the community, look, what 1 hour a month is doing for these moms prenatally and these families. At that time in 2019, one of the bigger, our largest MAT clinic in Arizona, and they are nationwide, heard about what we were doing at the one clinic. They received grant funding, and they said, can you start this hope group? And so we put together this hope group, and I'll talk a little bit about it and where that was. But we went there, and my very first day, just to kind of prove how the opioid crisis affects everybody, my very first day at the MAT clinic, I didn't know anybody. I show up, and I'm like, I'm Tara from Hushabye, and I'm like, and this is my niece, and she needs your services. She had opiate use disorder the night before. She'd reached out to me and said, I know what you're doing. Can you help me? And I was like, well, how about I pick you up? We'll take you and do your intake, and I will figure out what in the world I'm doing at the clinic. And that is how it started. Before we actually opened our doors, we had served 134 moms, with 80% of those babies being discharged to their moms safely from the hospital. In November of 2019, we received a huge donation of $800,000 to help create the building that we're in today. We actually, at that time, it was another building. We got architectural plans. We were with the contractors. We were ready to roll. And in December of 2019, I think it was the 29th, I got the call of, oh, that building they're going to demolish, because they just found out that the piping was, we knew the building was old, but the piping was not going to be able to do what we needed, which was very nice of them to let us know, so we didn't put in $500,000 to make it Hushabye, but we also needed to spend the $800,000. And at the same time, Access, which is our Medicaid system, heard about our $800,000 donation, so they matched it. But it came with a timeline. We had to spend it by September of 2020. So December 2019, we lost our building, and we needed to have everything spent by September, meaning we had to find a building, we had to buy all the supplies, we had to do everything. A little bit stressful. And then, if you all remember, January 2020, COVID started to hit. A little bit before we go into 2020, the green binder. Why did we start with the green binder? When I was at the clinic, my very first couple weeks there, we had a mom that had been in recovery. She had 2 kids out of homes that she was working to get back. She was supposed to be reunified within a month. She had her baby. She had met with me. I said, let's print out all your drug screens. She had 63 pages of normal drug screens. That's a long time to be well. She was on methadone. Her baby did withdraw. And at discharge, her baby went to foster care. Her plan for her other babies being reunified totally went out the window. I was like, did you show them your drug screen? She's like, I gave them to them. They didn't care. It was just a mess. The green binder came about at that time. Those kids, the baby and the other 2, took 9 more months to get them reunified. Mom never relapsed. Mom had a housing, she had food, she had transportation, she had healthcare. 9 months. And so the green binder is a program that we started, and it started at that time, which was just put all of your stuff in one place, have it be organized. This binder that you're seeing on the left is a mom that worked with us for 2 months. She'd been in drug court. She had all of her drug screens in there. She was doing like our safe sleep class, our car seat class. She had all of her certificates. And what they end up doing with the green binder is they bring it to the doctor's appointments with them. They bring it to the hospital with them. When they have their first meeting with our Department of Child Safety, they hand them it. What it does is it makes them stick out from everyone else that struggles with substance use. It makes us have a different mindset. With that mommy having her baby removed, we really talked about how could we have prevented this? How did it go so bad? And it went down to, after going to court with her, what was said or translated to the DCS worker was not the correct information. And I was like, I don't know how this got so messed up, but what was reported was not the mom. And I guess the only thing that I could say is the social worker was calling and doing a mandated report on 8 moms maybe that day, and she got everybody confused. But what came about was us from that point on trying to tell families, maybe if you call and you report your substance use yourself, or the fact that your baby is substance exposed, even if it's to a legal substance or to your prescribed MAT, maybe something better will happen, because you're going to be the first person that gets to tell your story. And what we found was the 2 parents that were on that video, or 3 parents were on that video, were my guinea pigs. And they said, I'm going to call, I'll do it. And they filled in this blank. They called the number. I was on a 3-way. I listened. DCS was like, I don't think you can like call on yourself. And they were like, no, I can, because I had already called. I knew that they could. And we totally took them by surprise. But what made it happen from that point on was you started to build a trusting relationship between child welfare and the family, because child welfare was like, you called and tattled on yourself, is what my family say, even though I'm like, you're not tattling, you're self-reporting, but they tattled on themselves. And DCS is like, okay, then they must not have anything to hide, or they truly want help. And from that point on, not saying that sometimes we don't have great interactions, but for the most part, the families that call and do the self-reporting have better outcomes. In the green binder, there's numerous things. There's 8 pages on the SAMHSA website that go over opioid use disorder. They go over pregnancy on MAT, why do you not wean off? That's in the green binder. When they have someone that doesn't understand, I say, take those 8 pages out and tell them to read it. When you're talking with a nurse that doesn't get it, or a home visitor that doesn't understand, you take it out and you show it to them. We have other things about like breastfeeding in there. There's a letter from myself with research that says, yes, it is okay and it is recommended to breastfeed if you're on MAT and MAT alone. The green binder, many moms will tell me it's their Bible, because it gives them the education to really feel empowered and confident in everything that they've done. They've worked really, really hard. And then fast forward in 2020, we found a new home in March. Remember, we needed to spend all of our money and have everything done by September. We started construction in May, all during COVID. All of our groups that were in person went to virtual, which at that time I was like, oh my gosh, our program is like, we're done. None of my families are going to be able to do it. They're not going to have any data to be able to access the groups. And our groups went from usually 4 to 5 to usually a dozen, and sometimes to 24. And it was like, oh my gosh, okay, I was completely wrong. And virtual was where it was at. In May of 2020, I hired my second employee that we actually paid. We really started having to develop all of our policies and procedures. And remember, I am not a business person. My person that was working for free, my board members, they were helping do all of this. For us to be able to be reimbursed for our services, we had to figure out with our health department, with the city, with our Medicaid system. We had to get everybody in the same room to go, okay, you're going to be licensed as this. We're going to say that you're this, and this is how you're going to bill under whatever code. It was a lot of work and a lot of begging for everybody to just have an open mind and to realize that, no, this hasn't been done anywhere. This is something that we're making up. But if it was your family, you would want that help. And we all came together and we were able to do that. The one glitch in all of this was you had to be licensed by the health department. We knew that. We had to go, pass inspection through the city. But for us to be able to get reimbursed through our Medicaid system, we had to be accredited by some accreditation body. And so is that JACO, like what they use in the hospital? We went for CARF, but to say that that is an easy accreditation is not. A lot of tears, a lot of, trying to figure out how do you get through. Well, we passed it. And then in November 2020, on the 17th, our first baby arrived. Had we opened in October, we would have had 13 babies that would have come to us. And then in November, we were kind of slow because we had 13 babies that were born in October. We had to order supplies. We had to continue to fundraise because we had to be able to, bill and to be able to get reimbursed. So just to review, our mission really is to embrace substance exposed babies and their caregivers with compassionate evidence-based care that changes the course of their entire lives. And so, yes, some of our care for the most part is evidence-based, but some portions of it are we making up? We do Eat, Sleep, and Console, but we also do the modified Finnegan to be able to look at the scores and compare. Are we going to treat? Are we not? Have we evolved as far as how much morphine we give and when we're going to give it? If a baby transfers to us already on morphine, I can remember the very first baby coming through the doors and, in the hospital, we wean a baby off by 10 to 20% a day. Here, the very first baby that came over on morphine, my nurses said, I can remember them refusing to give the dose. And they're like, come and look at this baby. And I was like, I already assessed them when they came in. And they're like, no, this is a completely different baby. And it had been probably 2 hours since baby had been there. Quiet, dark environment, completely different. And I agreed with them. We did not have to give that baby another dose of morphine. We just went from 0.05 milligrams per kilo to 0. And we were going to, give rescue doses if we needed to, but we didn't need to. So our initial policies and procedures of how we were going to do things from my experience in the hospital changed, and it continues to change. We have staff members. Everyone that works with Hushabye chooses to work with this population. It's not like being in the NICU. And I mean, for 17 years, my love was taking care of babies that were the size of a dollar bill. When you gave me a baby that was withdrawing, I was like, this is the longest 12 hours of my life. When that changed, why that changed, I don't know. Now this is my population. But I will tell you, when you have everyone on the same page, everyone with the same love and passion, you make families feel comfortable. And we know that babies withdraw easier with their mamas. And so really, that is what we try to make sure that they're coordinated with. So our care model starts prenatally and continues all the way postpartum up to a year, but then we're hoping to continue to work with them, at least doing check-ins every 6 months, but for them knowing that we're still there. When we meet them prenatally, we're initially, our very first words from any of my staff members when they meet a mom or a dad for the first time is congratulations. I don't care if they're high. I don't care what they look like. I care that they were connected to us some way and they took a chance and they're scared to death. And so congratulations. And I challenge every one of you, the very first thing you should say when you connect with someone, even if they're struggling, is congratulations. As soon as you do that, you start to break down the barriers and build up the trust. So we'll meet a mom and dad, say prenatally. First thing we ask is, we're addressing their social determinants of health, housing, food, transportation. Do you have that? If you don't, let us help you. Let's get you a place to stay. Then we talk to them about what's it going to look like when your baby withdraws. We give them a tour of Hushabye. We tell them, you know, this is what we can do. And then we'll say, these are the tips and tricks to make it easier for your baby to withdraw. And then their next question is, am I going to be able to take my baby home? And we talk to them about Department of Child Safety. And we talk to them about the script. And we try to alleviate them there. Then, only then, do we even bring up recovery. They already know that they're struggling. Are you open to recovery? Are you not? It's really hard to get well, to not use, if you don't have a place to stay, if you do not have food, if you don't have transportation. Those are things that need to be addressed first. And you need to answer those questions for the families that, am I going to get to take my baby home? And is my baby going to be okay? Then after you've done that, you can say, are you open to treatment? Some of our families are, some of them aren't. Some of them are still struggling. But if they are, we're connecting them with an OB that knows, that can prescribe MAT, or we're connecting them with a methadone clinic. We're connecting with residential treatment. We're doing all of that case management. And when I say we're doing it, we are doing it for them. We hold their hand, we walk step by step with them, we sit on the phone with them, and after we've shown them how to do it, then we watch them do it. And then later on, they can finally, fly. So we always say, give them one little win, one little W, and pretty soon it becomes a capitalized W because something big happens. When we meet with families, we really try to help them understand with the green binder, everything that's in there, but really for them to understand that they have opiate use disorder, that it's a brain disease, it's not a moral failure, and you're not an awful person. We really try to help them to really talk about their addiction as opiate use disorder, instead of I'm an addict, instead of I'm dependent on something. You have a diagnosed chronic illness that you're going to have for the rest of your life. And what you find is that gives them just the empowerment of going, okay, so you get it. You actually understand what I'm doing. And maybe I am not a bad person. Drugs make you do bad things, but does that make you a bad person? It doesn't. All of us really understanding that sometimes there's oopsies. Sometimes we relapse. When we relapse, do you have to spiral out of control? You don't. Maybe it's just an oopsie and we need to figure out what triggered that. I have a mom here in the nursery right now that had 6 years well. 3 months before she delivered, she was working in behavioral health. She was working with pregnant moms. And in 1 week, she had 3 pregnant moms overdose and die. She relapsed. She relapsed for a month. She told me that, and I was like, oh my goodness. And I said, well, we know your trigger now, which who would that not trigger? But we know what she needs to do. They're being discharged today, and I talked with her late last night. She's like, but I do want to come and work for Hushabye. I have my peer certification. I've worked in behavioral health. How long do I have to have being well for me to eventually be able to do what I love with the population? And with our organization has worked with her. The other thing that we really help families to understand is to go cold turkey when you're pregnant and you have a dependency on opiates is not recommended. It increases the risk of miscarriage or preterm labor. There's a really high incidence of relapse, and it's just not recommended by the American College of Obstetrics and Gynecology. For you on here that may not understand medication assisted treatment, which I did not, I didn't get it. I really felt like it was just a legal way to get drugs when I totally didn't understand it. but I'm gonna try to dumb it down the way someone dumbed it down for me, and I went, I get it. So if you and I had cancer, and you go to your doctor and they're like, there's 3 options. One option is 5% effective, another one is 20% effective, and the other one is anywhere from 45 to 75% effective. Everybody's gonna pick door number 3. All of us want to live. We're gonna go door number 3. With someone with opiate use disorder, door number 1, 5% effective, you go and you detox for 24 hours. 95 people out of 100 are going to relapse. When you relapse after being completely detoxed, the next time that they relapse, so 95 people out of 100 are going to relapse. The next time they relapse, they're 16 times more likely to overdose and die, because most often they use what they're used to using and it's too much. So door number 1. Door number 2, you go to a 28-day program, you detox, you're doing behavioral health, you're doing trauma counseling, you're doing all of that. Only 20 people out of 100 are going to be successful. If you go on medication-assisted treatment alone, so Suboxone, Subutex, buprenorphine, Vivitrol, methadone, 45 to 75 people out of 100, just that medication alone, they're not even buying in. They're just going every day, they're taking the medication. 45 to 75 people out of 100 are successful. So if we had cancer, everybody would pick door number 3. If we have opiate use disorder, why would we not encourage everyone to start on medication-assisted treatment besides us not understanding it? Me thinking that it's just an illegal substance for a legal substance and we're just drug dealers. It makes sense. They're prescribed it because they have a chronic illness. So our outpatient program for Hushabye, we offer all of these services. We hold about 40 groups a month, depends on how many days there are in a month. We do a lot of incentivizing. When families attend our groups, if they do the car seat safety class, they get a brand new car seat. If they do a safe sleep class, they get a brand new pack and play. For every class that they attend, they end up earning $15 of hush money, which they can then buy things in our little baby boutique, which truly is a closet with diapers, wipes, and baby items that are gently used that our community has donated. We have many moms that come and shop pretty much every week. They do groups all week, which means they're engaged, they're well, they're having check-ins, we're holding them accountable. They come in every week. I have a few moms that have never, ever bought diapers. One mom yesterday, her baby's walking, so it's got to be around a year, and she's not bought a diaper in her life. And she's now becoming a peer support and hopefully will work for us one day. But our inpatient services, so we have a 12-bed nursery here in Phoenix that we can serve the entire state of Arizona. You don't have to live in Maricopa County for your baby to come to us, but we have it where families can get treatment on site. So the NICU, bright beeping monitors, definitely not where you and I would want to go through withdrawal. One mom explained to me withdrawal as being the worst flu and migraine times 100. So imagine going to a rock concert when you have the flu. None of us would do it. Hushabye, this is us. NICU, Hushabye. So that baby that I was telling you about that came over on morphine, 2 hours later being in this environment with its mom and dad, that baby had mom and dad, not needing morphine makes you go, huh. And having one-to-one caregivers, quiet, dark environment, one-to-one caregivers, everybody embracing this family and not judging them so that the family will be there. This mom and baby, just what they said, every second we spent there, my partner and I felt welcomed and heard. Heard is a biggie. When we're doing our care, we have nurse practitioners that run it. We do have a medical director, Dr. Robin Lax, who's a pediatrician, that oversees like our policies. I can call her if I have an issue here, but for the most part, if there's something that we're concerned about, we reach out to the neonatologists at the different communities. I've worked with so many of them, and we'll bounce ideas off of them. But babies that have NAS alone or NOWs, when they come to us, they're well. Maybe they'll have thrush, maybe they need phototherapy, feeding tubes, but for the most part, they're well. How are we different from the NICU? Families can stay 24/7. Even during COVID, they could stay 24/7. We have one-to-one caregivers. We have a case manager that works with DCS, Department of Child Safety, specifically. She goes to court with them. She'll be on their meetings with them. She holds families accountable, but she also knows the system to be able to hold the caseworkers accountable, making sure they get their visits when they need them. And then you can read the rest of the slide. Everyone that is with Hushabye has been trained in NAS techniques, but on trauma-informed care, neonatal abstinence syndrome, opiate use disorder, all of those things, even for our volunteers when they're with us. I had said before that we do the Eat, Sleep, Console. Families do not have to be here 24/7 to do Eat, Sleep, and Console. We will do Eat, Sleep, and Console with our staff if that's what we need. So if a baby needs to be held 24/7, we're still doing Eat, Sleep, and Console. This is where I'm saying we kind of go off of the evidence-based practice. With the initial Eat, Sleep, and Console program, it's supposed to be, 2 caregivers from the family that are there to be able to provide that care. We'll have families, mom in prison, that baby's going to go to grandma who doesn't live in Phoenix, and we do Eat, Sleep, and Console with that baby, but with our staff being able to hold that baby.
We have 2 questions.
Yes.
Question 1, could you tell us more about the education you provide your participants on the CPS system?
Sure. So with Department of Child Safety, we, number one, tell them no matter what, they're going to get engaged. Our law says that any baby that's substance exposed, pot, even though we're legal here in Arizona, any substance is a call to Department of Child Safety. We help them understand that lies always come out. So say the truth, the whole truth, and nothing but the truth, because they always find out. If you use 7 minutes before delivering, tell them you did. Tell them that you want a parent. Admit that you're unwell, but that you really want to get well and help me with these. Our Department of Child Safety has so much to offer, meaning they have so many services and supports financially, electric bills, housing, that we can end up using them if you get the right worker to really buy in and see that this family really does want to get well. Sometimes that aha moment for a family is right when they find out they're pregnant. Sometimes it's at delivery. Sometimes it's not until baby's placed out of home and in foster care. Whenever that aha moment is there, we need to be there to help them with recovery services. Also with Department of Child Safety, we will help them understand their rights, that they have the right, that they should be getting their visits weekly, that what is it going to look like when you do their team decision-making meeting. I don't know in Texas what it is, but initially within 24, 48 hours, our DCS investigators come and meet the families. If this is going to be possible out-of-home placement, or a dependency of any type, even if it's in home, they have a team decision-making meeting. And that's where you have the investigator, the supervisor, and then any support systems that the parents have. So usually they'll have a peer support from Hushabye, they'll have our DCS case manager, they'll have their parents, any support systems, if it's home visiting, anything that they've been doing on those. That's pretty much our education to them, really helping them understand that their MAT is prescribed and that they're confident in being able to help explain that to their caseworkers and their investigators, because they don't know. The investigators just hear that a baby's substance exposed. They, for the most part, don't understand that it's a prescribed medication for chronic illness.
Okay, thank you. Next question is, what does 5S rock up and down and 6S squat refer to?
Okay, good idea. Let me go back to that slide. Okay, so the 5 S's are letting them swaddle baby, give them a pacifier so they're sucking, swaying, holding the baby and kind of going side to side with them. Oh, I got to think of what the other two are. The squat is, instead of when you and I do, when we're holding a baby, say our own babies, when they're crying, we bounce and we shake and we do this. When a baby is substance exposed, if there's anybody that is an OT or speech, they'll understand that it does something with the ears, the vestibular system. That bouncing is not helpful. If you're holding them and you do a squat up and down, that is where you can get them to soothe. If you go to our website, hushabyenursery.org, at the very bottom, you'll see a video that is me with long hair going through the 6 S's. But the 5 S's are from Harvey Karp, who has just soothing techniques for babies. Good question. Should have went through that.
Okay, you can carry on.
Okay. So inpatient, we are not the NICU, but we do everything that these babies require in the NICU at Hushabye, in a better environment made specifically for babies with NAS. Families can get treatment on site without having to leave. Now, if a family is on medication-assisted treatment and they still have to go daily for their methadone, we'll help them with transportation to get to the clinic and then to come back. They will have to leave for that, but can they be connected with our trauma counselor? Can they do therapy? Can they meet with our peer supports on site? Absolutely. We will try to have Department of Child Safety come to Hushabye and do their investigation with one of us, with the family there, because our families are scared to death. I will have the families that are so well, and they're not struggling at all. When Department of Child Safety comes in, they can't even talk. And I'm like, answer the question. But when you're nervous and when this is a matter of, am I going to get to take my baby home or not? This is what they've worried about their entire pregnancy. Many of my families, for the most part, these are not planned pregnancies. These are, okay, now I'm pregnant. I'm struggling with opiate use disorder. And now what do I do? They want to be good parents. They want it to be safe and they want to be able to provide for their baby. But how do they do that? And how do they help everyone understand that they've made bad choices in their life? Drugs make you do bad things, but they're different. And now they have the support system to come in and help them win 3 people that they're caring for in 1 week pass away on you. That mom said, she's like, had I known about you guys, I would have reached out. I didn't know that you guys were even around. And I'm like, you're working with pregnant moms that were struggling. I'm like, how did we not know this? So obviously us trying to understand everything is and market to our community is very, a very slow process. One story that I wanted to share, and this is not his true name, but we had a family that delivered their 4th baby at one of our local hospitals. The other 3 babies, mom struggled with substance use of polysubstance. They were homeless. Grandma had saw us on TV, reached out to us 48 hours prior to mom delivering. We were able to connect with mom. Mom and dad heard that they would be able to stay 24/7 with us. And they were like, sure, send my baby. We don't have a home. This sounds great. So for the first 72 hours, and this is where I'm very trauma informed, and I think I'm really good at talking with families and not being judgy. But with this family, I remember rolling my eyes going, boys, it's going to be a long stay. This baby, looking back, is the 2nd most impacted baby I've ever taken care of in 30 years. He struggled and struggled. I was like, oh my gosh, he really might have a seizure, for just how hard he was having it. The first 3 days, mom and dad were here. They ate, slept, left. I'm sure they were using, and then came back, ate, slept, left. They didn't really even pay attention to baby, that we could tell. We were like, okay, I guess Tara, my team was like, Tara says this is what we're going to do. I'm like, yep, this is what we're going to do. In the middle of the night, mom wakes up on the 3rd night and baby's crying. She gets up, she changes his diaper, she does all of his hairs, she asks for a bottle, she feeds him. All of a sudden she's mom. And the nurses are like, okay, I have no idea who that lady is in there, but she's amazing. And guess what? Her baby started to respond to her. We were able to start weaning her baby 12 hours later. That next morning when I came in, the nurses are telling me everything. They're like, I have no idea. They were totally taken aback. And they're like, can you tell that mom she needs to come back tomorrow? And I was like, sure. I'm like, so I talked with her, and I'm very upfront with our families. I don't sugarcoat anything. And I was like, well, your baby was a happy camper last night, and I would say that's because of you. And mom was like, what? Really? What are you talking about? And I'm like, well, he's been struggling for 3 days, and you were on it last night, and the nurses think that we can decrease his morphine. And she was like, really? And I'm like, so I'm so proud of you. And she got tears in her eyes and just a little trickle down, a little tear. And I was like, I'm so proud of you. And she was like, really? And I'm like, so if you can not do what you didn't do yesterday, and she starts laughing, and I go, you know what I mean? If you can not do that, he really needs you. And she was like, okay. Baby, we're going to fast forward 16 months later. So we're 16 months old today. Parents are in court today, I think, as we speak. They have housing. They work full time, both night shift at some fast food restaurant. They have been visiting. Mom reports not using from day 3 on with us. Dad struggled up until last July, but he's been well since. When we talk with families, we ask them what is different. Or when we talk with them, we ask them, what is different from before? And she says, and dad says, before with the other 3, they were able to visit the hospital for some reason, only 30 minutes. I don't understand, but they probably got caught using on site. I don't know. And they said when we would go to visit, it was, trying to take buses to get to see baby. Transportation was always a barrier. But when they would leave, their babies were always crying. And so when they were leaving, their babies were crying. And was it that they stirred their babies up and made them upset? Or was it that their baby realized that mom and dad truly are leaving? I think there's probably a combination there. But they just said it was just easier because they didn't need us. It didn't look like we were helping in any way. And when they were able to stay with us here, he was here. He was our second longest baby, being here with us at 27 days. Our longest has been 28 days. But they're like, we bonded. We want him. We know we can do it. We have the resources and the support. On the day before discharge, baby was going to foster care. Parents knew that. They didn't have housing. They didn't have, food, transportation. Well, they had transportation because we helped them, but they didn't have housing. There was no place to put them. Dad was still struggling. The day before being ready to be discharged, we asked the foster family if they'd be willing to meet mom and dad. And initially the mom was like, no, I know I'm not open to it. And 2 hours later, she called back and she said, yeah, I would love to meet them. She came and spent 4 hours that night with mom and dad, being able to show her what their little boy loved, what worked for him, the tips and tricks. It was truly co-parenting. The next morning, baby was going to be discharged. Foster mom came again, spent the whole morning. Dad and mom, we were able to coordinate residential treatment. Mom was only going to go to treatment if dad made it there, because she was like, I need to make sure he's okay. Dad's intake was at noon that day. We sent dad in transportation through insurance there. He started his intake. They called us and said he completed it. Mom was like, okay, I'm going. We're ready to discharge baby. We get baby in foster mom's car, in the car seat, get them all stable or safe and tucked in. And mom goes to get in her transportation to go to treatment. And the foster mom goes up to the car and is like, get out. And the mom's like, what? And all of my staff, we had not been open that long. This baby was our baby. He had been here for almost a month. We all loved him. We loved this mom and dad. And we're all crying. And the foster mom says, Mom, get out. And the mom gets out of the car and she's like, what? And the foster mom just embraces her and hugs her. And she's like, go get well. I have your baby. Go get well. So hopefully today, literally it is today, they are probably out of court, and we're hoping that he is being placed back in home. This family says that George saved their lives, and had they not been able to bond with him, they would still be struggling. So
We have one question that was
Yes.
probably asked before Gregory's story, because I think you might have addressed it all, but I'm gonna read it anyways, just in case I misunderstood. What does this program look like for mothers, parents that are not in medically assisted treatment and are still actively using? Are these families that are heavily DFS involved, foster placements? Has a foster mother ever roomed with their infant placement?
A foster mom has not roomed in overnight, because usually our Department of Child Safety does not give us a foster mom until day of discharge. So then we ask them to come and spend half of it a day doing 3 to 4 feedings to make sure that they got it. And then we can teach them the tips and tricks. But we have adoptive families that are able to stay. Foster moms would be able to stay too. Those families that are still struggling, even if they come in and they're under the influence, as long as they're not dangerous or disruptive, we want them here. Many times, and it happens frequently. We'll be like, okay, they're struggling. We have Narcan at every room and every place you can find here, just in case we need it. People that take opiates, for the most part, go night after they use. And so when a family comes in, they're struggling, we don't let them hold baby at that time. We will say, why don't you take a nap? And then when they wake up, we usually will be like, what can we help you with? What's going on? Are you ready for treatment? Are you not? Can they stay here? And they're still struggling. Absolutely. Babies have neurons that are working, that even if mom is just in the bed over here, that mom is doing something that you and I cannot do. It's definitely needed. Postpartum follow-up. We collaborate with so many different partners. It is not just Hushabye. Many of our families need intensive outpatient therapy. So we have a program called the HEAL program that is IOP specifically for pregnant and parenting moms only. We have different daddy programs that we connect them with. We have the trauma therapy, the Edinburghs. We do follow-ups at 48 hours a week, 2 weeks, a month, and then we go along the immunization schedules. So 2, 4, 6, 9, 12 months doing the Edinburgh, assessing for perinatal mood disorder, aka postpartum depression, checking on, did they get their immunizations? Is baby gaining weight? Have you went to your pediatrician? Do you like your pediatrician? Do we need to find you a trauma-informed pediatrician? Connecting with home visiting. We do the developmental follow-up clinic. All of those different things. A huge part of that is, yes, we want to make sure families are connected, but we really want our data. We want to know what we're doing. Is it working? Is DCS still involved? Did mom relapse or dad relapse? Is baby still in home? All of those things. So here's our outpatient, our newborn follow-up and everything that we do. The Vines program is a program that one of our community partners, it's a virtual neonatology. If you have, instead of going to the doctor, the pediatrician for, say, you notice thrush in the mouth, you can, for the first 30 days after discharge, you can click a link on on their computer that we set up, and a doctor comes up or a nurse practitioner, and they can go, here, look at the baby's mouth, and then they can write them a script instead of having to go to the pediatrician. It saves a lot of emergency room visits for things that don't need to go to the emergency room. We make sure that they're connected with WIC and SNAP, making sure that they have the food that they need. We have the high-risk perinatal program, which is here in Arizona is kind of like developmental follow-up clinics, but on steroids. Same with Arizona Early Intervention. We connect them with all of these so that hopefully they're getting the support that they need, because we know these families and these babies are at higher risk. Our journey in 2021, still trying to secure all of our insurance contracts. We have a lot of grants that we work off of, reimbursement from them. So we may have a contract, but it doesn't mean that we're still getting reimbursed, because, oh my gosh, there can be glitches. You can have a comma out of place and you're not going to get paid, which is really frustrating on my end. Developing the referral process. Systems change is really, really hard. And here in Arizona, getting the hospital systems on board with thinking of Hushabye as a collaborative relationship versus a competitor. Yes, we're taking babies out of the NICU, but we're keeping families together, and we're able to do that all while meeting the needs of the baby. And so 98% of our families are on Medicaid. Again, cost savings, $60,000 compared to $7,000. Us as a community, Hushabye is a no-brainer. Keeping babies together safely with their parents at home and not putting them into the foster care system, increasing adverse childhood experiences, seeing whatever chronic illness they have down the road, 40, 50 years down the road. The amount of cost savings that our program brings to us, I don't have a number. I have someone doing their thesis that I'm trying to con them into doing that. Do that research and give me a number of what we could possibly save our community with our program. Really, we're still working on being sustainable. We've served to date 271 babies. Our number, which you're going to see the impact report, this was based after being open for 13 months at the end of last year. I think I've addressed most of these. I have not addressed our use of pharmacological support. Only 25% of our babies require pharmacological support. Half of those babies came to us on morphine, and we needed to continue it. But half of the babies that come to us on morphine, so the babies that come to us on morphine, only half of those babies do we ever need to even give one extra dose of morphine. The quiet, dark environment with caregivers that are one-to-one that all understand that if the baby needs to be held 24/7, the baby's held 24/7. We are staffed with neonatal intensive care unit nurses, 2 on. Even if we only have 1 baby, we have to have them to be able to resuscitate. We have patient care assistants, which are like certified nursing assistants. We have volunteers, and then we have AmeriCorps. We received a grant for 14 FTEs to help us be able to meet that one-to-one. And they're trained to do inpatient, but also to do outpatient. So they do a lot of those check-ins at the 48 hours, the week, 2 weeks, and going forth. Looking at families that are unified, 77% of our families, if they're engaged prenatally, and I actually think that number is now 80%, if they're engaged with us prenatally, 80% of the families are being discharged with their parents safely. Now, is it just to the parents? A lot of times not. A lot of times we have what we call responsible adults, which is maybe a grandparent that passes a background check, or an aunt or an uncle that's willing to care for baby 24/7. But the parents, as long as they're well at the time, they can be there and parent. So not all of our families, I'm not going to say that 80% never have DCS and they all go home. I would say probably half of them still have DCS engaged and they have the responsible adult. But we're keeping families unified, and we're making it that they mitigate the adverse childhood experiences. We have
one question.
Yes.
Sorry. Do you guys have a plan in place for a birthing person who ends up experiencing postpartum psychosis in addition to being active addiction?
Say that again.
Sure. Says, do you guys have a plan in place for a birthing person who ends up experiencing postpartum psychosis in addition to being in active addiction?
Yeah. So yes, we partner with Women's Health Innovations and Allium. Women's Health Innovations, that is their specialty. Perinatal mood disorder, psychosis. We work hand in hand. They actually were founded about the same time as Hushabye, and so we really have grown together. We're really trying to see if we can expand where we're at to a center for excellence, meaning we would have them next door. And then we would have an OB and a pediatrician that all are trauma informed and all understand the population that we're working with. That's what we're really working for. But yeah, we do have that if we need it. I have had the experience. I've learned. I had one mom that was having an issue, and we did have to petition to have her, I don't want to say committed, but to be evaluated for 72 hours. That wasn't fun. That was the pits. We called the crisis line, called Women's Health Innovations. It was like, okay, what do we do? And she just needed help. And after 72 hours, she was able to come back in, care for baby. Is still struggling though with mental health and with substance use. Let's see, what else are we doing? Marketing, trying to everybody to know what we're doing. Our goal is anyone that's ever caring for a baby should understand what Hushabye does. And what I mean by that is anyone that is a touch point to a baby, pediatrician, you and I, should know that Hushabye is an option. Just like we know going to the hospital is an option. Everyone knows someone that's struggling. We just don't talk about it. I think we're getting better at talking about it, but we're not there yet. We have now gotten to the point that our Department of Child Safety actually recommends Hushabye. We had the director and someone from Washington just recently come and look at our model, and they're like, oh my gosh, expand, do this. And I'm like, well, help me fill up my unit right now. If we were full, meaning that we didn't have the barriers of getting babies from the hospitals to us, which there are babies galore. It's just being able to get them connected. We're getting there. I have 7 babies right now on our 12-bed unit. So today I'm a happy camper. Here's our outcomes to date from before. 67% of all of our babies that have been in the nursery are unified at discharge, meaning we had not worked with some of them prenatally. 80% of our families that have been engaged with us prenatally are home with their babies. About 30% of our families are able to breastfeed. What else? I think all the others we talked about. Just another sweet mom and her talking about what we've done. And with the future, what does it hold? With the rising overdose deaths, we know that there's rising NAS cases, NOWS cases. Our numbers we have in Scottsdale, that our statewide numbers say that our one hospital only has ever had 2 babies with NAS, which I totally know is not true. When I talk to my peers, it's just the reporting is not great. So we know here in Arizona, our numbers are low. I don't know about you all, but we have tribal areas too. And for some reason, tribal do not have to give us their data. So they're not even included in our data when we're looking at cases of NAS. One mommy just recently said, I hate saying this, but I have no one to fight and I don't know what to do anymore. But I'm so scared just to get close to her, and her baby's here in the nursery now, because I don't want her to get taken from me. And so we have a long way to go still. When she said this, I was like, oh, mom is still struggling. We're working with her. Is she ready yet for much treatment? No. I mean, she's jumped on a couple of our groups, but still actively using, and her baby is being discharged today, and baby will go out of home because there's no other family that has been identified for baby to be able to be discharged. But when you hear that she had texted me prior to this saying that I don't want to come and meet her because I'm going to get too close. And then when she goes into foster care, I'm going to be brokenhearted. We need to really decrease the stigma, really change the way we talk for us to be able to make a difference in the families that are struggling. Just be kind, don't judge. We have no idea what anyone's been through in their life. And for the most part, when we look at adverse childhood experiences, I don't know our average number, but I've had many moms that are 10 out of 10. They've been through a lot. And that is it. All of the slides you guys can have. I will put my name and phone number and my email address that you guys can always call me. Text is great too. I probably am better at that than others.
Yeah, the PowerPoints are in the course, so they're accessible. We are recording this and it will be made available for what's called Enduring CE. So if you have a coworker or somebody else that didn't get to see the live of all the NAS presentations, it takes us about a month to get all those organized and put up, but they'll be posted on the NAS website for the next 2 years for CE. You do have a few more questions. What caregivers besides the parent do you employ?
Anyone that the parent agrees to, anyone that the parent agrees to. We do very much like the hospital does. So 2 people banded, and then the banded people can bring visitors in. We just started that. Before it was whoever was banded or whoever the baby was going to be discharged to could come. So say with the family that I was telling you about that hopefully is being reunified today, hopefully. I let the mom and dad, and then I did let grandma come in. Grandma was out of state, but we were hoping she might move in state. She didn't, but we change the rules all the time. That's what I should say. I make crap up all the time. So if with our families, I feel that we always need to change and exceptions are always made. I get a lot of phone calls and I get staff that will be frustrated going, Terry, you made the exception before and today you're not. And then we talk it through and explain why we're doing it. But if we have a family that's struggling, but we know baby's going to go home to grandma and grandpa, that's 4 people that I want to visit and 4 people that really need to visit. Because what if mom and dad come and they get engaged? One of my staff says the right thing at the right time that I'm able to get them into treatment. I need them there. And grandma and grandpa, I need them to be able to care for their baby. But say that it's a best friend that it's going to be, discharged to. They're the ones that are going to be able to be. Our rooms aren't big, so two people in the room is all we can have at a time.
Somebody has a comment and an idea. They want to create a DCS program where foster families, where the responsible adult would be the foster parent, mom goes to foster care with baby rooms in the baby in foster home, etc. Seems like a big impossible dream, but that's the dream. There are so many moms that would be appropriate for this type of program.
You're exactly right. I don't know. We have kind of 2 sets of foster families. We have fosters that truly foster and they want reunification, but we also have fosters that are foster to adopt. Depends on who you get. We don't ever get to choose the foster family. I have another case that a family was just reunified that mom was able to go to the foster family. I mean, she shared her number from the very beginning. She sent pictures every night for this mommy. But she was able to go and visit at their house whenever she wanted. And now they've been reunified and she's like, I need daycare. And the foster family's her daycare. And I'm like, that's the way it's supposed to work. And so now they're just a big old family. She can call and be like, can you take him? And they're like, absolutely, we want him. I mean, they have cared for him for so long and they love him. And they understood where the best place is being. So you're exactly right. That's the dream. And just knowing that it truly, this can be, maybe I'm not supposed to say this anymore because I don't know that's politically correct, but it takes a village to raise a baby. I have a really big village that helped me raise my kids. And could I have done it without them? It would have been a really hard time. And so that's what we're trying to help families do, is be connected with others that can help them succeed.
Amazing. All very amazing. If y'all have any final thoughts or questions, just type them in the chat. We'll be ending in about 2 minutes. There's just a lot of thank yous. Wonderful presentation. You're doing such a good job. Thank you for the work. Lots of kudos. Your passion is inspiring. Thank you for sharing with us today.
And if you have any questions, you guys, you have my my contact information. If I don't get back to you within, say, 48 hours, reach out again. Texting, I'm usually good. You'll get a response within an hour, but email, I will tell you I went on vacation and I'm still in email jail trying to get caught up. So.
All right. Well, we truly appreciate you so much, Tara, and all the work you're doing. You've given everybody so much to think of and so much inspiration in our own communities. You have a wonderful day, and thank you everybody for attending.
You too. Take care, everybody.
Bye.